All right, let's kick off the rest of this afternoon. Our next panel, Flight Path to Wellness, Prioritizing Mental Health in Aviation, will tackle the critical issue of mental health within the aviation industry. Please welcome NATCA's Executive Vice President and panel moderator, Andrew LeBovidge. Aviation Medical Advisory Service, Dr. Kurt McCartney. Federal Air Surgeon for the FAA, Dr. Susan Northrup. Peer Support Chair, Airline Pilots Association, and Airline Assistance Chair for Airline Pilots Association International, Travis Ludwig. And Flight Standard First Officer, Allied Pilots Association, Evan MacPhee.
Great. So, thank you all for being here. Thank you, brothers and sisters. In the spirit of these conferences where we learn from each other through our exchanges of information, I did learn from the previous panel that this particular time slot is the least opportune time to have a panel due to, and not to misuse terms of art, our circadian rhythms. That notwithstanding, I do believe you are in for an exciting panel. We are going to have a conversation this afternoon with 4 of the preeminent experts in the fields of aviation medicine and peer support. So before diving into the conference, I do want, or the panel, I do want to allow each individual to introduce themselves with a little bit more depth. And I'm going to start here with you, Kurt.
Good afternoon. I'm Kurt McCartney. I'm one of the physicians at Aviation Medicine Advisory Service, or better known as AMAS. We are contracted through NATCA to be the medical support for union members. So we're a free service. We're strictly confidential. You'll speak to a friendly voice at the other end of the phone, and we want to help. So if you're not familiar with us, I would invite you to visit our booth at the back of the exhibit hall, and I'd be happy to share more with you.
Fantastic. Susan?
Good afternoon, everybody. Thank you for having me back. I was here last year with Andrew and Quay Schneider. What he didn't say is he's retired Air Force, and so am I. So, for the Air Force folks in the crowd. But I'm the Federal Air Surgeon of the U.S. I took the job in January of 2021. Prior to that, I was the Southern Regional Flight Surgeon in Atlanta, so several of you I've met along the way. And let's see, I did touch and go through an airline and the military, so I'm going to give it now to Travis.
All right, thanks, Andrew. Thanks for having me. Travis Ludwig, Airline Pilots Association, Pilot Assistance Chair. First, let me say thanks for having me. Fresh off our own safety council or conference, I got a little envy seeing your guys how you do it. We're going to have to step up our game, so I'll be in trouble for that one, but I definitely appreciate being here and seeing how many faces are in the audience. The Pilot Assistance Chair is kind of an innocuous term. It doesn't mean much to most people. It really is the mental health and physical health of pilots. That's kind of what we're concerned. We do fall under the safety committee as a safety organization, but we have split off kind of the technical airspace, what we normally think of as safety, and split it off and did pilot assistance and all of the mental and physical health kind of as a separate branch. We closely intermingle with each other, but it's definitely something that kind of had to be split off because we got so large.
Fantastic. Evan?
Hi, everybody. I'm glad to be here, too. It's my first time, so I'm the newcomer to the group. I'm a 777 pilot for American Airlines, and I'm on leadership for Project Wingman, which is our peer support program for the Allied Pilots Association. I'm also on the Professional Standards Committee and Sudden Grief Response. And all the committees at APA work hand in hand with each other in helping the pilots. But today we're here to talk about my work with Project Wingman and what we can contribute to today's panel.
Wonderful. Again, thank you all for being here. As Susan said, about 1 year ago, almost to the day, we held our first aeromedical panel at CFS, recognizing that aeromedical issues are a critical component of airspace safety. In that 1 year, things have become, there's been a lot of activity. You know, last year we talked about the past, the present, and the future. Well, it seems the future got here pretty quickly as there have been a lot of changes. And one of the things that was at the heart of it was back in January of this year, the FAA administrator chartered what they called the Mental Health and Aviation Medical Clearances Aviation Rulemaking Committee, an ARC. This ARC was tasked, it had 5 tasks, and sort of focus on the first 2 because I think they're of the most relevance for this conversation. It was to identify factors that prevented clearance holders from reporting mental health issues and to make recommendations to the FAA on how to overcome those barriers. The second recommendation was to develop recommendations for the FAA on how to address mental health diagnoses. That ARC was commissioned in January. In an intense 90-day period, it concluded its work and issued a report on April 1st with 24 recommendations on how to address those tasks as chartered. Travis was one of the co-chairs of the ARC, and I wanted to start this conversation with you, Travis, if maybe you can provide some additional insight and background on what the ARC activity was and how we got to the ultimate report on April 1st.
Thank you. It was quite an uptick. It was quite a lift that we had to do for this ARC. A fairly short window. We had a lot of dedicated volunteers. Andrew still lives rent-free in my head because every time we would say, well, the pilots have, and he would say, controllers, pilots, controllers, and we just, we learned how much, I learned personally a lot what your medical process was. It was really eye-opening to see how much, some commonality and how much differences there were and how we had to thread the needle to make sure that we included both controllers and general aviation, 121, 135, all of those folks. So it was a really big undertaking, and I really thank Susan for her leadership of kind of putting all the right people in the right place, closing the door and letting us work through this process. And I think, I'm a little biased, but I think we got some good recommendations out there.
Fantastic. So, Susan, while you weren't a voting member of the ARC, you were sort of the shepherd and sort of the SME who helped navigate through some really difficult conversations. But coming out of the ARC, we have seen some changes through your office. And perhaps you can not just elaborate some of the changes that have occurred over the last year, but perhaps its interrelationship with the ARC work and how that affected how the recommendations affected your taskings.
Largely, hugely. So actually, we had been doing an awful lot in the field of mental health within the Office of Aerospace Medicine for several years when this happened. And how did we get there? The most recent thing that had occurred in the aviation industry was a pilot who was having an issue due to a substance pull a fire handle or a set of fire handles on an airplane. But that wasn't the only thing. There had been a couple suicides that we were quite concerned about in the aviation community. So we set some goals in the Office of Aerospace Medicine even before those had occurred. And that was to get everybody we could back in the air or controlling aircraft as soon as it was safe to do so. And we want to do it in a transparent, repeatable, reliable fashion, because that's critical. Trust is a huge barrier. It was one of the top 7. Mm-hmm. And how do we get there from the people that depend on my office for their clearances and their certificates? So, before the ARC, many of you are aware that we had 4 what are called selective serotonin reuptake inhibitors, or SSRIs, approved for use in safety-sensitive personnel, pilots and controllers. The process is a little laborious, and we had just the 4 for a long time. So a year ago, we added Wellbutrin. That was the first drug we had added. When they stood up the ARC, and we listened really hard to what the experts were saying. Now, so who was a member of the ARC? Andrew was from NATCA. We had somebody from PASS. We had lots of people from industry. We had people from academia. We had an astronaut who was good at risk management. I mean, the list of people on this body were truly impressive and had your best interests at heart as they were doing their work. So we sped up a bunch of things we were doing. In April, we added 3 new medications that are allowed. Those are called selective I can never say it. neuroepinephrine reuptake inhibitors, SNRIs. So there's a total of 8. In a year, we've doubled the number of medications allowed for people that need it to return to service, as it were. In May, we posted the biggest change for the Guide for Aviation Medical Examiners in the last 20 years. So how many of you know about the Guide for Aviation Medical Examiners? I see a couple of hands. Granted, I got bright lights in my face. That is the cookbook, if you will, for the AMEs, the Aviation Medical Examiners. We have been working very hard to get the right information in there. So if somebody is diagnosed with a condition, as soon as they get to home and if they've recovered from the, oh my God, I didn't want to hear that point of view, go there and look at what we're going to require. You have people to call. You have Kurt and his group at AMAS. You have your AME, you have your doctors, but if you go in there and take the documents that are there to your provider, they're going to know what we're going to expect. That's the transparency. There were a couple other really interesting things in the May response. So those are some of the huge things. That particular release, there are 13 different diagnoses. You can have up to 2 of them. If you've been off the medication for 2 years, and there's a whole bunch of other things that have to be met, but the AME can issue your certificate and your clearance. We're applying the same thing we do for pilots to the air traffic controllers. So that's a huge step. And we let you continue in therapy. You can still get a medical or a clearance. If you're on medication, you'd have to go through the other thing. So in June, we looked at that and said, this is great work. Now how do we get the people that are already in the system that would meet these criteria into this track? So there's a way for somebody that's waiting for us, if they meet those criteria, the AME fills it out and sends it in, and we pull them out of one queue and stick them in another. More to come. More to come. We're going to shorten the time frame of how long you have to be on a medication before we can consider you for return. Exactly what that's going to be and when it's going to be released, I don't know yet, but it's coming, and it'll be before we meet the next time. That I promise.
You stole one of my questions in advance, so I guess I'm going to have to check that off the list. But it's encouraging to hear. And I think that's, not to go too far away from the ARC recommendations, but one of the things discussed was how it is being applied across the international community. So learning from their experiences has been a part of your calculus in making these determinations?
The international? Oh, it sure was. So, as many of you are aware, we as the U.S. lead a lot of international efforts. They follow us. However, there's a lot to be learned when we talk to our international counterparts. EASA in Europe had been looking at barriers to care and how to get to people. They have a really slick, very polished report on it, and we've considered that. Our friends in New Zealand and Australia are looking at what they're calling MESH, which are AMEs with additional training. They're going to roll that out here real shortly, and we're sharing the information so we can develop a best practice that's international.
Fantastic. So another oh, go ahead, Travis.
If I could just point out too, for our Europeans, it's actually mandated, the peer support stuff.
Yes.
And so there's a whole data set and a different model over there that's also kind of growing it organically, separately from us, and it'll be interesting to see what those.
So, and that's a great segue, that peer support comment and the mandate over in Europe. And perhaps, Evan, you can help elaborate. So we talk about peer support. It's been mentioned in this conference and in other NATCA events and small regional meetings. But we sort of had the surface understanding of what a peer support program is. So Evan, maybe you can sort of provide us a little bit more granularity, a little bit more detail on what is a peer support program, and certainly from your experiences at APA, how is it used? Project Wingman is a vibrant program, and maybe you can share some of its background.
Sure. Thank you for asking that question. And I saw a question that's up from someone in the audience that asks, most controllers are still suspicious of resources available. What steps can be taken to assure them? Well, that's where a peer support program really comes in, because it would be fellow controllers that are in the same situation. The reason that Project Wingman is so successful is because it's peer pilots. It's other pilots there for other pilots that have been in a dark place in their life before, and they can get down in that space with that person that's concerned or having an issue in their life and can connect, because that's what builds trust, is that connection. When you have someone that's been through a life event, that's had challenges, and they can make that connection with someone and sit in that space and listen. And the hardest part of somebody that's coming out with something is the fact that they think that they're going to be a burden, or they think that no one's going to listen to them, or no one's going to get them. A peer support program does just that. It allows that person to have that bridge between that dark space they're in and getting to where Susan and Kurt work.
Yeah, and if I could piggyback
Absolutely.
on it, I think it's very telling that I get teased by my folks in the union about being the touchy-feely guy, right? We're the soft kind of, how do you feel about this? What do you think about that? But really, those of my CIRP, we call it CIRP, you guys call it CIRT or CISM, that really came from Special Forces. Dr. Paul Sargent actually reviewed our peer support program, and he told a wonderful story about in his years with Special Forces, being psychologists for them, they would come in, get their debriefing, sir, I'm fine, I have no problems. 3 hours later, he'd see them in the O Club just pouring their tears out to the guy sitting next to him, because that was their peer. It was somebody they trusted and could open up to. And so I really challenge, if you have the ability to talk to someone else and sit with them and walk with them, that's what peer support's about. It's being able just to listen and be human with someone else. And that's a huge release of that barrier, and lowers it so that more people can step in and get the help they need, and hopefully earlier.
And I know what the next question would be is, oh, well, it's just a bunch of pilots or a bunch of controllers sitting in a room. How do I trust? Well, peer support, we're all specifically trained. We learn pilot personality. We learn about the different life challenges that can go on. And we have a staff of 2 full-time psychologists, medical advisors, and a legal counsel that support us in the work that we do. So we have a whole list of vetted professionals that we use that enable us to give the support to the pilots that they need.
Yeah, and that peer really becomes the conduit between those outside resources that may or may not be trusted, and the pilot in fear or controller in fear.
Yeah, I love Dr. Morgan's hole analogy, because that's peer support for me.
It is.
It's the friend that falls to the bottom of the hole that you fell in and knows the way out. Because a lot of this is normalizing response, and if we don't talk about it, then it's liable to fester. And if it festers, it may end up leading to additional higher level care and a diagnosis, and now you have to deal with me,
Right.
or somebody a lot like me. My goal, and I really believe that this is going to take the entire aviation community to change the stigma, the fear, the shame, and the avoiding of care, and getting the tools you need to respond effectively. And it's got to start with a bunch of people beginning to do that. And if we do this right, they may never need me, because they fix it before it gets so bad that you have to have some significant intervention.
And that it comes back sort of to the arc, because some of the barriers that we did try to address were fear, stigma, ignorance, process issues. Going back to the peer support programs, perhaps, and Travis or Evan, either one of you, do you maybe give us some insights into how they were originated at your airlines? What was the initial steps that were taken? And I realize they may predate you, but certainly if you have an ability to perhaps communicate sort of that chronology, what transpired to allow Project Wingman to be developed, or your programs to be developed?
You want to take this one
No,
first?
go ahead. You want to start off?
The echo was really bad, so I couldn't exactly.
Oh, okay. Yeah, so development of the program. Much like the ARC, we locked ourselves in a room for a long period of time. The nice thing about mental health is it is kind of much like safety, an open book policy, right? What I do, best practices, we like to share. We like to tell people what we do well, what we don't, and really get multiple venues to come together and think about that. So we stole from here and there, cherry-picked from some of the best programs. Wingman has a couple nods in our slides as we built it. The ability to listen to another person, a few real generic mental health first aid type diagnosis definitions. What's anxiety? What's depression? How do those present? What makes it is? And then we harped a lot on resources, what's available with that. And then really showing courage to give them hope and encouragement to say, look, you're not the first to go through this. You're not going to be the last. I'm right here to walk with you. I can't carry the bag for you, but I can definitely be here to point you in the right direction to help take that load off. So it took a lot of people together to do it, but we did it in much more of a vacuum back in 2017, 2015 than there is now. So I think the development process won't be as painful as we had, but it's definitely, you definitely have to take what's out there and make it your own, because everything's so different.
Yeah, I'm sure with controllers it's the same as pilots. We have there's a pilot personality out there. It's a type A. I can fix everything, and so that we long before me, it was back in 2011 actually, a group of pilots identified that there is a pilot personality, and they saw that these pilots were, in times of stress, turning to their fellow pilots when life challenges were getting overwhelmed. So that's where they came up with the idea of let's get a group of us together to be there for these pilots. And that's really all it is. We're there for people. There's still, I have in my calendar an alarm will go off for someone that I helped a year ago, and it'll remind me to be there for someone that lost their child, on this day 2 years ago. And I'll call them up a year, 2 years later, just to check in with them, just to let them know that, hey, you've got 15,000 pilots that are behind you here, that are on the sides. You're not going through this alone. And that's what people need to hear. That's what allows them to have that assurance, to feel that it's okay, because there's other people out there going through this too.
Yeah, I think that's a great point. You break your arm, you have a death, somebody shows up with a cupcake and says, I'm sorry you're feeling that way, and you may not see them ever again. Peer support really fills that gap into the long term. Anniversaries are tough. Holidays are tough, and so we tell our folks that we teach them that those are the times to make that extra reach out. Even if it's just a quick text that says, hey, I'm thinking about you, it means a lot to that person on the other end to receive that.
So just by having those conversations and having those resources available, it helps break down that stigma.
Yes.
And it becomes more accepted to be able to address mental health issues in the community rather than hiding them for the most part.
Yeah, it becomes much more organic that you build it up from the inside, that you fly with somebody or you work with somebody and they went through that, and hey, you're not looking as well as you normally did, right? Somebody's observing, and hey, why don't you call them? I called them, it was great, right? I talked to them. They gave me the resources I needed to get me through that really tough time.
Yeah, we actually have made a matrix sheet with all of our volunteers and what life issues that they've faced, so that when someone calls up and they have something specific, I can ping that person and say, hey, we've got someone that had such and such happened. Can you take this one? Because now that person's going to align better, and they're going to feel that connection that they need to get through it. Not just talking to a random person that doesn't get me. No, this person walked this walk, and they can walk with you to get to where you need to get to.
So, and maybe to sort of transition a little bit to you, Kurt, because you see both pilots and you see ATC. In those communities where they do have peer support, how do you see that in your interactions and as you try to interface on their behalf with the regional flight surgeons?
Sure. Yeah, the peer support program is a fantastic program. I think it's broken down the fear barrier, at least. And it's a great first tool, and oftentimes the issue can be resolved at that level. If not, then the peer pilot can assist the pilot in question, or we can, in getting the help they need. And like Susan said, early intervention is the key. We don't want to end up having to deal with or support a pilot with a much serious problem. Not only is it not good for their health, obviously, but it also can complicate their future certification. So I think we've seen an opening up on the pilot side of pilots willing to call us and discuss mental health issues. Unfortunately, we don't see that on the controller side. There's still a lot of fear there, and you can see it and hear it in their voices when they call us, even though we're confidential. They're scared about finances. They're scared about losing their employment. They're scared about the process that they'll have to go through to get their certification back. So I think the PSP, the peer support program, has been a phenomenal success.
And I think process is another, it was a barrier that was identified, and maybe Susan, you talked a little bit about process as far as reducing the time perhaps at some point on how long you have to be on a stable dose of a particular medication. Perhaps stepping back a little bit without getting into too detail, but can you give the audience a little bit of a view on what the process is right now if you are diagnosed with a mental health issue? Perhaps, I know you referred to the uncomplicated anxiety, uncomplicated depression, which could be, issued by the clearance could be issued by the AME. But in the event that it's not one of those, can you kind of give like a high-level overview of what actually transpires from the time of diagnosis to be able to get back to work?
Sure. So, generalizations. Each case is different. There's always little nuances, but if you look at the process across the board, if the individual doesn't need to be on medication and they get the help they need and report it, we'll ask for reports from those providers and we'll render a decision, providing somebody's stable. We want somebody stable, okay? If you end up on a medication, right now you have to be, and it's one of the approved ones, the AID, you have to be on it for 6 months. There's a couple of studies you have to get, some neuropsych testing to prove that it worked, and then you have to come back through us for a waiver. If you'd asked me the question 9 months ago, the wait time was going to be way higher than I wanted. Right now, from the time we receive everything, the wait time is about 2.5 months, if everything is what we asked for. So it's really, really critical to go out there to the Guide for Aviation Medical Examiners, talk to Kurt and his bunch, talk to your AME, get the list of what we're going to want, and make sure you've got a check in every single item. Because if it's not there, we're going to send it back, and I don't like doing that. Then you'll be put on a special consideration as an air traffic controller. It used to be, and this is one of the big changes we've done in the last year, that once you were in the antidepressant program, you had to have annual neuropsych testing. So never to let a crisis go without some benefit. During COVID, we did a real deep dive into the 450 some odd pilots we had actively flying in the program and asked the simple question, did the neuropsych testing change the outcome in the absence of clinical findings? And we found none. So we got rid of the requirement for annual neuropsych testing, unless there are clinical indications. So it's gotten cheaper, thank God, but you'll still have to have the first set. We are working to speed that up. A couple of helpful hints is make sure you read everything that's going to be sent into us so there's no inaccuracies in those reports. Because if somebody said you had, let's say Crohn's disease as a child, and that's not true, we're going to ask questions because we do read it. So make sure you've done that before you send it in. Make sure your name's on it. You'd be amazed how many times we get documents that aren't, who is this? We don't know. And there's no doctor's signature. So make sure that you've gone through it. If you haven't seen my pilot minutes, on YouTube Pilot Minute, one of the first ones on how to expedite your medical, it still applies for you all. The simple tools and techniques there. The other really cool benefit is once you've read through it and your treating providers have read through it, if you know you have to have neuropsych testing at whatever point we say you have to wait, which right now is 6 months, and you wait to schedule that until day 181, neuropsych people are scheduling out 4 and 5 months. But if you schedule it as soon as you're responding to the medication, you'll have it when day 181 comes around. So it'll shorten that time frame a lot. But work with the people who are
That's what I was just going to say. Work with us if you run into that situation. If you get a diagnosis, call us right away. We'll tell you what the process is going to be, what the requirements will be, and part of our service is to review those records before they go to the FAA, and oftentimes we're the ones submitting them on your behalf. So please use us.
So, and along those lines, though, one of the things that we've heard, despite Susan's best efforts to train AMEs, have you encountered any
situations where AMEs perhaps aren't necessarily up to speed on some
For
of the-
sure, yeah. You know, like with anything, there's a range of knowledge out there. Even though it's listed specifically in the AME guide, some AMEs who handle these types of cases don't follow the guide for whatever reason. So yeah, there is that, and that's why we're here, to help you, to make sure everything, all the boxes are checked, you've got everything done, so that you don't have all this back and forth, because that gets into the process question of greatly delaying your certification. So we're there to help, and we're happy to do that.
And Susan, just to peel away a little bit of a layer there, I think you have made some significant efforts to globalize training of AMEs, and maybe you can elaborate on that somewhat.
Sure. I'm going to use my 3 E's then. You've given me an opening.
We finally, not 5.
You can tell I do a lot of talking, and I'm very passionate about this. So I have 3 E's, my main talking points when I go out, if I'm given any period of time with a microphone in my hand or on my lapel. The first one is education. And it's educating the users of our system, you and the pilots, on what we're going to expect. And we do that through forums like this. We do this through webinars. ALPA put me in front. I got to meet your new president that way. I go out and I talk to groups because we have to start from the ground up to get people convinced to do this. So education. Then we started educating the AMEs because we do have a wide spectrum of capabilities in our AME population. But now we offer the last Wednesday and the Thursday after that what we call grand rounds every month. Not going to do it Thanksgiving, sorry. But we spend an hour with the subject matter experts and we talk about the new changes. If we don't have any new changes that month, we do case studies where we walk people through the cases and how the new standards apply. The second E is early intervention. And if we can get people the care they need and the tools they need early in the process, the likelihood of getting through quickly goes way up. If they wait until they do something final or attempt to do something final, it's a lot harder to get their clearances or their certificates back. The third E is evolution of standards. And we have been doing an incredible amount to update our standards based on the current science. So if you go to the Guide for Aviation Medical Examiners, it's public facing. We update that the last Wednesday of every month. So it behooves you to periodically go back in there and take a peek. Because we might have changed it. We're changing it awfully fast. Real quick before I forget, the number one recommendation of the ARC was to allow talk therapy without having to be reported. We are working our way through that because finding a definition of what talk therapy is a bit challenging, and it varies from state to state. So we're right now working very hard to get our hands around what that is and what needs to be reported versus not needing to be reported. So right now you don't have to report marital therapy, family therapy, if you go talk to your pastor, but if you go talk to a professional and you end up with a diagnosis, you have to tell us.
Peer support's also not reportable.
Yes, peer support is not reportable. Thank you.
Nor is talking to AMAS, which is, you know, I'll plug them. We use them. I was a former air medical chair. And the first question somebody would call, hey, I just got this diagnosis. Great, I don't have MDs behind my name. Let's get those folks involved and let me help you with how we're going to deal with the company. That's a confidential call. There's no better place to get on up to minute information about how to get stuff done. Checklists in hand so you can go to your general practitioner or wherever you're being treated and get those knocked out. And so it's a great service and it's union dollars well spent.
And that cannot be reemphasized enough. The services AMAS provides to help navigate the medical landscape is invaluable, invaluable. I do want to go back then a little bit. We're sort of getting close towards the end, but I did want to highlight one thing. And you mentioned it before, but just to make sure there's clarity. We do have, in the air traffic world, a very vibrant critical incident stress management team. They do phenomenal work when there's an aircraft accident, incident, and in a way sometimes try to bridge that gap that we have by not having a peer support program. But for you, Evan and Travis, maybe you can elaborate on the differences between CISM or CIRP and peer support? Because they seem on the surface similar, but there are some differences, and maybe you can help fill in those blanks.
So true.
Yeah.
You want me to?
Sure.
Yeah, so I think in the development of the program, that was the first real internal hiccup we had. CRP had been filling, or CISM had been filling a need out there, and I think you guys have a grief. They were also doing grief. Outside of their ICISF real charter mission, but filling a need that was done. So kind of decoupling those two and figuring out where that real line was. And we drew the line in the sand to say it's on the job incident or accident. That's where CRP really does their mission is best served there. Everything past that or long-term issues with an incident, an accident, really need to be handed over to people with a different set of toolboxes. That's all it is. The base underlying is, can you listen to a pilot? That's what assistance is. However, the CRP has a very structured model to get you from trauma response back into the green, as we say, where peer support, PPS, has much more of a long-term goal and much more I'm going to walk you through this very long marathon together so that we can get things out.
I agree, and you brought up a lot of good points. Our other committees were born from the peer support of Project Wingman. Yeah. We started out that way, and then we realized that there were different tranches of support that's needed. And so we formed CIRP, and then S Group, which is Sudden Grief Response. And then we realized that they're more of a Ready 5 team that go out right away to help the situation. And then once the family or the individual now needs a little bit longer term talk therapy or someone to discuss things with, we'll help them walk through to get their way to the therapy and stay with them longer through that. But the committees do work hand in hand together, just like professional standards. NATCA is already has a big advantage with going to peer support because of professional standards. There's so many times that a pilot's called into professional standards for their anger behavior or some kind of conflict, and in talking to professional standards, we realize that there's an underlying issue going on at home. And we're able to figure that out and take care of that symptom with peer support. So having professional standards is already a leg up on your way to peer support, like Project Wingman is what we have.
Yeah, we often describe it as a beach. All of my 6 different committees live on the same beach. They're all doing the same mission, helping someone get better. They're doing it in somewhat siloed sandboxes, but they have to know what's going on next to them. Aeromedical may get a discussion about a diagnosis, and it turns out there's much more in there that peer support may need, or there's a pro-stands issue that comes up that, this is reaction from a stress reaction that CRP now needs to be involved in. Or our peer support folks are talking to them and mean, what do you mean you lost an engine? Nobody talked to you about it. Let's go talk to the CRP folks and let them do some triage on you too, right? So we're all playing together with a specialty.
We like to say professional standards is what happens in the cockpit or what happens in the tower, and Project Wingman is what goes on at the dinner table. So this way they're covered everywhere they go, and you go with the proper committee to get handled whatever's going on in your life or at work.
So, and I guess the next step for that, and I asked Susan about international medical standards, are there international communities for peer support? And if you want to maybe describe what those are and sort of broaden our knowledge of the universe at large.
Yeah. I'll speak to it real quick. There's actually a conference going on in Osaka in November that we won't be able to attend, or we would be there.
Yeah. Brazil.
And it really is an interesting child that they've developed over there. So it came out of Europe. Europe has, again, like I said, regulated mental health care. There's some ISO rules that they live under and our Canadians live under that specify in the workplace there needs to be mental health care. So they have actually kind of pushed it down from the regulator down upon both the union and the companies. And so what that ended up borne out, because they are a much smaller population than we are. We dwarf from almost tenfold as far as pilots to over here to there. And so they've actually expanded their team, and so they bring in flight attendants, mechanics, air traffic controllers, firefighters, anybody that touches that airport that might have a peer model and need training for that. So it really opened it up and gives us a much broader view of what best practices are, because at the end of the day, we're all human. We're all red on the inside. We all have the same problems. We all suffer from really just this human condition. So learning from other people how they creatively found ways to get around certain obstacles and how we can take that back to our individual properties and make it better is really a benefit.
Yeah, piggybacking off what Travis is saying, been my observation in different committees that I've been in different sectors of aviation, that the best peer support program is going to be very resourceful, not just within their company or their department, but with other airlines. We work with ALPA, we work with United Airlines, we go to all these conferences, and it helps because we're on a unified front from different perspectives. And that's what this is all about. We're providing perspective to the individuals that use the system and to the users themselves between the different companies.
So, last year we talked past, present, future. Now we're talking present again. What do you see in the future for peer support or mental health? And I guess I'll start with you, Susan. I know you elaborated a little bit, but what else is next? What's next for mental health issues?
Well, we're going to continue to apply the evolving science. Medicine is making huge leaps and bounds. If you'd have told me when I graduated from medical school that stage 4 pick your cancer was ever going to fly again, I'd have gotten, you got to be kidding, because they were death sentences. And I'm dating myself, of course. But now there's new things out there that we can consider. I mean, Prozac didn't come out until, gosh, okay, now I'm really dating myself. I was in med school. But the proliferation of medications with few side effects is accelerating, without a doubt. And what we're learning is just amazing. I mean, we're getting really close to a lot of things that will turn a corner and allow people to return to controlling our safety-sensitive duties. Once we get all of the improvements in our policy out into our AMEs, then we're going to start talking about a period of non-enforcement. But I have to have the bits in place to get people returned quickly when they come forward and say, hey, I've been doing this or I've needed treatment, so that there's a safe space for them to land in a quick way that's adequately resourced to get them back. So that's coming. Really beginning to put safety management system concepts into the decision-making from an aeromedical point of view. We are to the point in medicine that it's moving from expert opinion, which is where so much of it is and has been for decades and centuries, to what does the science say? And how do we take our databases and compare them to the big house of medicine and make really good risk-based decisions?
That period of non-enforcement was a very important recommendation that came out of the ARC, especially for the controllers here in the room who have clearances. I guess, Evan and Travis, from your perspective, what is next in the peer support world? Is there an evolution? What improvements can be made there?
So our I want to say biggest hurdle, but right now, like I like Susan's 3 E's, and it applies to peer support as well. Called the law of 3 E's by Susan.
Take them, use them.
But right now, it's awareness, and I don't mean awareness that we're here and we're available, and that if you're having a challenge that you'll get back into work quickly, but having each individual pilot or controller have awareness about themselves. Do a self-check. Peers, do checks on your fellow controllers and pilots, because let's face it, we're get-it-done people. We get in there, we have long hours, we have a lot of work to do, and we don't always realize that we're going through something. So to do that self-check before you walk in the door or when you walk back in at home, or check in with a coworker, that's what's going to really move the needle, because we can only help the people that come forward. It's the people that don't know they have a problem because they're not checking themselves. So that's the next hurdle for us, is to get more people to have awareness about if they're going through something.
And Kurt, I'm not going to leave you out. What do you see? What's next from the AMAS perspective?
I think from our perspective, first of all, hats off to Dr. Northrup and her advocacy and push to change things in a positive manner. That can't be emphasized enough. So we're waiting, like she says, to see what happens next. Is it shortening the amount of time somebody has to be on an antidepressant? Get into the talk therapy, is that going to be reportable or not? We don't think it will be.
I think a lot of it won't be reportable.
Right.
I
And
have
where
to
we're
put
trying to
boundaries
get
around it.
is try to address those barriers that were identified by the ARC. And I think we're making progress. It's all about safety, right? And I can't emphasize enough also what Dr. Northrup said about early intervention. We always recommend do what's best for your health first, and we'll help you with what FAA issues may arise, if any. But that's our mantra, and we stand by that. And we're hoping that this continues, and I'm sure under Dr. Northrup's leadership it will.
And I think with about a minute left, that's a fantastic place to close, is the reminder, and we do it as well, emphasizing to our peers, take care of your health first. The rest will follow, and we will help you through that process along the way. So as we conclude this panel, I do want to thank you again. Your efforts, it's the continuous pushing the rock up a hill, and it's without your efforts this would not move forward. So everyone here is actually making a difference, and I hope that the experiences that you all bring to this stage will transport into our occupations, on our aviation safety professionals that we work with to help them overcome issues in the future. I look forward in the future to working with you all again, and I would ask the group to thank this team for the work that they've done in the mental health arena.